Anyway, good morning. Good morning, everyone. Really thank you for joining us at this ISOS meeting. 14th, actually AP valves, we've changed it Seoul valve from this year. So anyways, we want to start the first live transmission session, since I am very happy to have David Cohen is here, and distinguished panelists, moderators, Hayashida, Duk-Woo, Hoon-ki, right, Mahn-Won, right. Thank you for joining us. Right, we want to start. We prepared 3 consecutive live cases from Asan Medical Center, Severance Hospital, and Seoul National University Hospital, and so we're gonna start with the first cases. Okay, ready?
Good morning, SJ.
Can you hear me? Can you hear me?
Good morning. Yes,
right.
I can hear you.
We have many distinguished panel and moderator here, and so would you start the first cases?
Yes. Good morning, SJ, and good morning, Eberhard. So welcome to the Seoul valve, the new name of previous AP valve. So we are in the Asan Medical Center. So this time, this is the first case of new meeting Seoul valve, first live case of new Seoul valve meeting. So we prepared the severely calcified aortic valve disease. This session, I'd like to talk about how to deal with the severely calcified aortic valve disease by the TAVR. So I'd like to introduce my team, the Dr. Park and Dr. Wee. So Dr. Wee will introduce our first case. Could you please?
Good morning, everyone. I'm Seung-Jung Wee, a clinical fellow from Seoul Asan Medical Center. I'd like to briefly present today's case. Our patient is a 73-year-old male who presented with dyspnea on exertion, classified as NIA class 2. His BMI is 26, and his calculated STS score is 2.7%. His medical history is significant for diabetes, hypertension, and hyperlipidemia. On ECG, he was found to have RBBB, and the chest X-ray showed mild bilateral pulmonary congestion. Transthoracic echocardiography revealed a left ventricular ejection fraction of 66%, an aortic valve area of 0.53, a mean pressure gradient of 75 mm mercury, and Vmax of 5.5, raising suspicious for severe aortic stenosis with mild regurgitation. As shown in parasternal long axis view, mild AR was found, and in the short axis view, restricted motion of aortic valve leaflets with heavy calcification and flow acceleration was observed. In apical 4-chamber view, preserved LVEF of 66% was observed, and AVMAX was 5.5, with mean pressure gradient of 75 mm mercury was also observed. On CT finding, we obtained cross-sectional views at the annular level, as well as 2 mm, 4 mm, and 6 mm of the annulus. The annulus area measured 513, and the sinus of Valsalva was 827, and the sinotubular junction was 578. And LVOT measured 535, and aortic valve calcium volume was 1,222. Coronary height were measured at 9.2 millimeter in LCA and 19.7 millimeter in LCA, indicating quite a higher risk of coronary obstruction during the procedure. Valve to coronary was 5.7 millimeter, and leaflet length was 14.7 millimeter. The patient peripheral arteries are fine without heavy calcification or severe tortuosity, with a minimum diameter of 6 to 7 millimeter, which is adequate for transfemoral access. Based on our measurement, the 26 Edward Sapien valve would provide 1.1 area oversizing on nominal, while a 29 millimeter Medtronic Evolut valve would provide 12% the parameter oversizing. And now I will hand over to Professor Ahn to discuss our TAVR plan.
So thank you, Dr. Wee. So do you have any comment on the question on a patient from the moderators or panelists?
Hi, Dr. Alan here. So I couldn't see the CT so well. Is this a bicuspid type 1, or is it? It looks like the sinuses are quite weird in terms of the shapes as well.
Yes, based on the CT finding, there is just some fusion between the right coronary concept and the left coronary concept. So it looks like the bicuspid type 1, but not definite. But anyway, it looks like the bicuspid. So considering the very high calcification volume, relatively young age, so I'm more favoring to say bicuspid rather than tricuspid.
I mean, first of all, good seeing you again on stage here. And I wanted to ask you, if you do coronary protection or plan to do coronary protection because the left coronary is kind of low, when you do protect, are you just using a wire only, or are you placing in your practice? Are you placing a balloon with a stent already in the coronary?
Usually, we use the wire and balloon, not stent. So
Yeah.
in this case, the coronary height. Please look at the aortogram. I think there is enough space for coronary perfusion even after the valve implantation. But the problem is leaflet length. Leaflet length is more than 14.9 something. So my concern is sinus sequestration after the valve implantation, not direct occlusion of the leaflet to the coronary ostium. So the upper part of the coronary height is around 14. The leaflet length is around 14.9 something. So because of a very long, although there is enough room, very big sinus, but considering the very long leaflet and low coronary height, so I'd like to put the wire and the balloon in the coronary.
Yeah, plus you can see how the leaflet behaves when you do when you predilate. You see how the leaflet behaves then.
Yes, that's a good point. So very severely, usually the predilatation is not our routine practice in nowadays, but particularly in this case, the severely calcified valve based on the calcium volume more than 1,000. So definitely we need the predilatation. During the predilatation, we do the contrast test aortogram. So we can check the behavior of chunk calcification.
Yeah.
Anyway, Dr. You selected balloon expandable Sapien series, right?
Right.
Could you explain the, difference and why did you select that one?
Yes, there are two types of balloon: the self-expandable and balloon expandable device. First of all, almost all cases, around 80%, more than 80% of cases, we can do both. But particular this case, I believe that the complication characteristic is different. The balloon expandable valve high risk of aortic valve injury, aortic root injury. Self-expandable valve, high risk of permanent pacemaker implantation and the paravalvular leakage. Look at the EKG first. The EKG show that the RBBB, in case of RBBB, the high risk of permanent pacemaker after valve implantation, particularly a self-expandable valve. In addition, we can modify the volume in the balloon expandable valve. So I believe that we can safely implant the balloon expandable valve even in the very high calcified aortic valve, very severely calcified aortic valve disease. In addition, patient age is 72, so considering the future access to the coronary, I'm more favoring the balloon expandable valve less than self-expandable valve.
So,
Jung-Min, also because Asan has a lot of experience with bicuspid valves, is your implant technique, your positioning, your anchoring any different from tri-leaf or tricuspid valve?
So most different point is the calcification volume. Severely calcified, because based on our data, basically bicuspid valve is two times the higher calcification volume in the aortic valve leaflet. So if calcification is very rare, very low calcified aortic valve disease, even bicuspid is very similar to the tricuspid aortic valve treatment. But very severely calcified bicuspid aortic valve, we should be careful for the aortic root injury in balloon expandable valve treatment and high risk of paravalvular leakage in the self-expandable valve.
So I think the most critical point this patient is most audience wondering about which valve type is suitable for. I would like to hear some national preference and David and Kentaro and bicuspid very severe calcified region, and what is your first choice for valve type?
Yeah, thank you very much, Dave. Hi, Jung-Min. Thank you very much for the demonstrating very nice case. And I didn't appreciate that much the RF in this case. Did you say type 1 LR? And if so, maybe I would think about the length of the intercommissional length. And in terms of the choice of the valve, I personally prefer to choose a sapien because of the minimizing PVL. And some operator prefers to choose the self-expanding device, but it totally depends on the anatomy or how much risk we can take. And because in this case, the patient have the pre-procedural AR, maybe we don't need to eliminate the PVL in this particular case.
I think that
So I already insert the wire and balloon to the coronary. So I try to
they have a balloon.
cross the.
We would, I mean, the difference with our center is, as you know, we're pretty aggressive with leaflet modification, and I think if we're as worried as you are about, we rarely protect the coronary. If we protect the coronary, we just, we split the leaflet with a bacillus in this case. But it's obviously there's lots of places around the world that do it this way, which is seems to work fine, and I predict you'll be okay anyways, because I think the sinuses are so big that I think it's going to be all right.
And in terms of protection, I prefer to put 2 wires because when we need to put a stent in the coronary, so we can use the balloon as a slip-through technique to deliver a stent.
Say, are you pre-dilating bicuspid valves, or are you just don't?
We do.
You do.
In all those
Yeah.
cases. I think bicuspids,
Yeah.
one case where most people will always predilate, just a little bit higher. Just unpredictable in a lot of ways.
because if the valve doesn't cross, it's just a pain in behind.
Yeah. Yeah.
As you can see from the other room today,
Perfect.
all the other modification technique is painful to solve.
Please give me the balloon. So I selected the 20 millimeter balloon.
Size-wise, what size?
20.
20.
And you're planning a 26, right, Jung-Min?
Yep.
Yeah, right.
Smaller one.
So nowadays the pre-modification is emphasized in case of the new valve systems to avoid the under-expansion. But fortunately, Sapien 3 radial forces, I think, enough. So we need just to open the valve to deliver the device. To avoid the outlet injury, I want to a little pull the guiding catheter for coronary engagement. So we need the aortogram to see the behavior of chunk calcium. Ready? Inflation. Deflation. Pacing off. One more.
What kind of balloon are you using? You use it.
This is
What's the
G-made
name
balloon.
of balloon? G-made balloon.
Do you have the true
One
balloons?
more.
Do you have them now? It's not. Still not. Yeah, still not. It's just
Facing on.
Atlas balloon. Yeah.
The Z-mat is just so thin
Inflation.
and it tends to move
Yeah.
around a lot.
Action.
Contrast.
Okay.
Deflation. Pacing off. One more. I needed more engage, more. 따라 올려. Okay.
Good. Hold on.
Pacing on. Inflation. Contrast.
Perfect.
Deflation.
Yeah. Wow.
Pacing off.
Very severe calcium.
Yeah, and you can see there's a lot of sinus for flow into the.
Yeah.
That's reassuring, although this is a 20, but this is a 26. Size is going to be a lot bigger.
I think Jung-Min was worried about the native valve leaflet was kind of long, right?
Yeah.
So when they pin up, it doesn't matter what the sinus
size
base is sequestration.
You still have to get.
Unfortunately, you won't be able to know.
So what is your sizing? What is your sizing algorithm for bicuspid in
So-
Sapien?
Very similar to the tricuspid.
Relatively small. The meaning is, in case of a balloon expandable, we use the kind of area of sizing. Say in the case of a low calcium, it would be a 10%, something like that. However, bicuspid, heavy calcification, almost equal 0% of sizing and less than that one. We're gonna start them and then get going.
So in this case, the 26 Sapien is almost the nominal size of 26 Sapien is a 1% area oversize.
All right.
So we reduced the 1 cc undersizing, so around the 28% oversizing. So actually undersizing valve this is. So after implantation, there is no regurgitation stable. So I'd like to stop procedure, but significant PVL, then I do. If it's after the aortogram, I'll do more. I will decide to do more additional ballooning or not. 임플란테이션 앵글로 가주세요. Test please.
Perfect.
You can see the wire centralized quite nicely once you kind of go across and pull back a little bit, so anticipate no issue crossing there.
됐어?
Test please. Okay.
That's good.
Facing on. Contrast. Inflation. Okay. 끝까지. 1, 2, 3, 4, 5. Deflation.
Great.
Facing off.
So the angles are quite off from the valve standpoint.
Maybe 70.
We only
30,
severely
something.
calcified
Good
the
position,
valve.
right?
나가자. 나갑시다.
I want to know why in Korea it's always 1, 2, 3, 4, 5, and in the United States it's 1, 2, 3.
On the US.
We were much more hurried. We only go to 3.
So let's check the aortogram. Ready?
It's okay.
Okay.
Yeah,
It's tight, though.
So fortunately, patient there is no AV block, the sinus rhythm. Diastolic pressure is more than 50, very high. Definitely the very small PVL. Could you show us that the echo, please?
Yes.
Is it Jung-Min, at the time of the valve implantation, you seems like guiding caster tip is just more pull back 3 and 4 centimeter? Is it
Yeah.
your intention or any?
Yeah, because I don't like to make some damage to the ascending aorta. Aorta is a little bit big, so I intentionally pulled away from the coronary ostium. So usually, this is the usual our technique.
Are there cases you would do with a stent already in, or you almost never do with a stent already in the vessel?
A very, very, very high risk of coronary obstruction. Very rare case. I'd like to insert a stent, but in this case, I don't think a very high coronary obstruction risk. So I just place the balloon only.
As you know, still sometimes the problem, and you remember from DW in my case many years ago, trying to get past the edge of the leaflet can be difficult advancing the stent, which is why it's nice to have the stent in the coronary if you're really worried.
Yeah, maybe take us through a little bit, Jung-Min. If there's a problem, you would pull the balloon back. How would you put a stent in here? Because your wire is pinned by the valve, the tip of the top of the valve and the aorta. How are you going to get a stent in there?
Another guy.
I think it's
Shows
perfect.
echo.
Perfect.
I presume that you might have to get a balloon there,
Yeah,
guide liner
don't
it, and
know.
try to slip the guide liner through
Pericardial
the.
effusion.
You can just
No pericardial
beat on it for a long time. I
Could you
mean, I
show
think
us
it's
the
hard.
paravalvular leakage?
That's why a lot of people still put a stent.
Put a stent in there.
No
David.
significant regurgitation.
David, can I ask you a question?
Huh?
I don't want to be provocative, but
Don't ask the question.
But on bicuspids, I mean, the jury is still open about many things. So do you really think that all the open questions in bicuspid will be resolved by randomized trial, the two that are ongoing?
All, of course not. We never resolve them all. But I think we will get answers to, a couple of important questions. The most important is what proportion of bicuspid valves are truly suitable for TAVR? Because we don't really know that. We know how many patients we're treating, but we don't know how many we're rejecting, that we're not treating. I assume that at Asan that happens as well. Is there some anatomy and the patient is lowish risk? You say, let's not worry. Let's just send them to surgery and we'll deal with it when this one fails. So I think that is the biggest issue, and then we'll find out in reasonable patients where an interventionalist is willing to take them on for a TAVR, can we match surgery? I mean, I'm still not entirely sure that we're going to be as good as surgery. I think that is the answer I want to hear. And I think these two studies will give us a pretty good sense of that. But we'll never get all the answers. The other answer is long term. What about, these patients who are in their 60s, young 70s, who are going to need a second procedure, maybe a third procedure? That's a completely different question. We won't get the answer to that from these trials, at least not, for another 20 years.
I don't remember the sample size, but obviously there's a lot of different types of bicuspid valve, right? So
Yeah.
it depends on how you enroll at just like selecting a process. There might be ones that you just don't even consider. So therefore,
Well, I think
the process, right?
the design of both of the trials that are being proposed, Stefan Windecker's one and the Raj Makar's one, they mimic what we wrote about 6 years ago, which is that the studies need to have registries that collect data on the patients that don't get treated either with surgery or with TAVR, so we know the proportions, we know what what is their anatomy. We need to have very nice image banks of all the CTs, so we can really try to tease out if there are problem patients that we can learn.
I mean, for bicuspid valve for surgery, unless the patient is high risk for some reason, right? The surgery
You can always do
is
it.
no different.
Yeah.
Right, the surgery is not like they cut harder or they have to do it.
No.
So for them, it's really dictated by the STS, meaning that are they the age, other factors. While our problem is that
The anatomy.
every different bicuspid valve confer different risks
Yeah.
from the procedure standpoint. So it's a bit almost like almost startup. You compare different things already.
Jung-Min, can you check it up the coronary osteum or
Minus, please.
Yeah.
Coronary ostium
We
is
already
okay.
checked the coronary.
Flow is
So
okay.
using the
What is that?
No
using
AR
the
anymore.
guided
What-
catheter.
26.
So
You
What
can
is
see
the
the leaflet pretty
contrast?
nicely
Fine.
there.
Isn't that the contrast of outside the valve leaflet of the native valve leaflet tracking down?
Is that the
What is that thing?
that looks like
I think it's a leaflet.
Yeah.
The leaflet
Yeah.
outside the leaflet.
Yeah, outside the
Yeah,
leaflet,
outside the leaflet,
left
I
main
think.
ostium.
Yeah. It is not a definite test, but it looks like the good. It looks like good, so I like to remove the pigtail, and I like to remove the whole system
Alright.
from
All right.
Okay, can you?
coronary,
Easy. Okay.
and
Did you routinely come back to
Oh.
take an angiogram without a wire, just to make sure that it wasn't holding something open?
Absolutely. Yeah, we check it up again.
Or do an aortogram at least?
so aortogram again,
Something just...
final shot, aortogram. Ready?
Looks okay.
Actually, no AR. Diastolic pressure is very high, so coronary looks fine. So I like to finish my procedure. Fortunately, the patient baseline rhythm was our right bundle branch block, but fortunately, we don't have any AV block so far. So definitely, the patient, even though very calcified arterial
good, yeah.
disease with a very low coronary height and baseline RBBB, so we finished the procedure with a successful result without any complication.
Will you manage this
do you have
patient
any
any differently and after they leave the hospital? Will you give them a monitor? We often will give these patients 30 days of telemetry for to make sure, especially with an existing right bundle. Is that anything that you do, or is that not very unusual?
We don't usually
So-
check it up. Yeah.
It's our routine, so we do it
30 days. At,
Yeah.
yeah. Okay.
two Zeo patch.
I think the measuring the native leaflet height is a little bit kind of not quite sure what it means, right? Because if it swings up, it's not a flat piece of tissue going up, it's sort of curved.
Yeah.
So the highest point is where you measure the leaflet, and probably here is touching, but blood flow goes around it to get into the coronary, right?
I mean, the best study on predicting coronary obstruction was Jaffer Khan did a study a few years ago and said as long as the coronary does not, basically the valve doesn't go higher than the commissure, you're okay. I mean, the commissure is where the action is. So you just have to look, very carefully on the CT to see if the commissure is.
All right, Dr. Ahn, that's really
Yes.
thank you for your live good live demonstration. The tough cases, bicuspid, heavily calcified, aortic stenosis is simply balloon expandable. Thank you for
Yes, I advise I know the next two cases in the Severance Hospital and Seoul National University Hospital will prepare the live case using different heart valve system. So please enjoy more. Thank you.
So we're gonna move second cases from the Severance Hospital. Okay, Dr. Young-Guk, professor.
Yeah, good morning.
All right, can you hear
hear
us?
me?
All right, so
Yeah.
it's your turn. So
Okay.
we have many distinguished, panelists here. So you can start.
Okay, good morning. So it's our honor and pleasure to demonstrate our live case. Welcome to Severance Hospital. Let me introduce our team. So on my right side, Dr. Hoon, who is my mentor, and we have another little Hoon. Seung-Jung is participating in our procedure. And Dr. Hong-Ki John, who is a fellow in our intervention in our hospital. And we have a very supportive team of nurses and technicians. And we have also support from the anesthetist for our case. So, Dr. John, could you introduce this case?
Yes. Hello, everyone. I am Hong-Ki John at Severance Hospital. I'd like to present our live case. The patient is 80-year-old woman, and her chief complaint was dyspnea, near class 2. And she has a history of diabetes, and lab finding was non-specific, and SC score is calculated with 3.4%. Next. And chest X-ray and EKG shows unremarkable findings. There's no conduction abnormality. Next. These are TT findings. Ejection fraction is preserved, and aortic valve is tricuspid with degenerative change. And aortic valve velocity is up to 4.1, and the mean pressure gradient is up to 43 millimeter mercury. So aortic valve area is calculated with 0.9, and it is compatible with severe AS. Next. CT finding shows annulus diameter is about 24 millimeter, and the LVOT diameter is similar with annulus, and the sinus valsalva diameter is 31 to 33 millimeter. Next. And both coronary head is relatively high, and aortic valve calcium volume on non-contrast imaging is over 1,000, and there is reflex calcification, especially on NCC. Next. Annular angulation degree is 44 degree. Next. And there is no special risk for vascular access route. Overall aorta size is relatively big, and there is no excessive angulation. Next. And CT finding shows middle LAD and middle RCA moderate stenosis. Next. So recommended valve size is about 29 millimeter of evolute.
Next. And next slide. Yeah, and also for Sapien 3 system, 26 millimeter valve will be the right one for this case. Next. And when we choose Navitor, then 29 millimeter valve will be the right size for this case. So do you have any comment about this case? This is a relatively straightforward case, so I think all valves can work very well in this case, but do you have any comment?
Hi, this is David Cohen. You don't have yet the FX Plus Evolute here, with the large cell sizes, right? Not yet?
No, we have FX only.
So this one, with all the calcium in the coronaries, I just think that having good coronary access is relevant, and seems like it might be a good case for a Navitor. There's not so much calcium, so again, the issue of radial strength is not the most important factor. The most important factor, I think, for this patient is preserving good coronary access, and I think you can get that with the Navitor. So that would be, I think, a very reasonable choice. I wouldn't fight you if you said I was going to do it with a Sapien as well, but we just saw one of those, so I think we want to see something else.
Dr. Cole, I'm Dr. Lim from Taiwan. You only have the information of the coronary tree from the CT. Will do the invasive coronary angiogram to check what about moderate lesion before you
when
do
we
the
have the
TAVR?
moderate stenosis, the cases, then we check the coronary with the angiogram. Yeah.
Right, in the, mean the 16 and 17% oversizing, so based on the perimeter or area, so what it is? 17% oversizing based on the perimeter or diameter or areas. What it is?
This is based on the perimeter and the diameter, so not based on the area. Yeah.
Perimeter?
Yeah.
Yes.
Great. And I missed actually total amount of calcium is based on the CT findings. Would you show us that one? Calcium.
Back. Yeah, yeah.
Total calcium?
130.
All right,
Yeah,
great.
yeah,
So not so much.
Yeah, not so much.
It's quite good, right?
Yeah, so I would say it's a mild to moderate calcification. Yeah,
Actually,
yeah.
we're gonna see that in the distribution of calcium itself is non-chloride calcium, right side, the left side is totally different one.
There's
And in
some
terms of,
calcium-
in some cases, low chloride height, we have considered about sinus ratio and location of calcium itself. Okay, thank you.
Yeah. Yeah, so the calcium is located mainly tip of leaflets and no calcium in LVOT or at the level of annulus. So basically, this is, as I said, it's a straightforward case and the calcium burden is not that high. As I mentioned, I think all kinds of valve system will work very well in this case. But, as already Asan Medical Center demonstrated sapien valve, so I think it's time to demonstrate self-expanding valve, which is more familiar to us. So this is Evolus system. So
No, actually, this is comment is something wrong. What I mean is, if this patient is the not live case, we do a sapien, but we already assign for the evolute by the SJ bar.
We understand.
Myeong-Ki Hong, you second operator, you
Yes.
look younger than Dr. Oh, it's really inside. I didn't realize who you are in the beginning. All right.
Can I make a comment?
yeah, so let's show the angiogram. So
Okay, excuse me. There's a comment.
Mr. Kim?
Regarding the issue raised by Dr. Cohen, the cell size is very important for the accessibility of coronary. But another important factor is commissural alignment. To my experience, until now, navigator system is very bad in terms of commissural alignment. It is impossible, just depending on fortune. But in Ablett, we can adjust commissural alignment. That's so-so. Cell size is big with navigator, but with Ablett effects, we can adjust exactly commissure. That's, I think,
That's a good point, a very good point. Now we have, as I said, we have the FX Plus in the United States, so we can get both. We can get commissural alignment and a big cell. So hopefully sometime soon, if you're here in Korea as well.
Yeah. As Dr. Kim mentioned, I think commissural alignment is very important for self-expanding valve with tall frame height. So this is, we inserted temporary pacemaker through the right internal jugular vein. Next angiogram. Yeah, and we use intracardiac echo to monitor the procedure and also to check the amount of palpebral leak and complication after valve implantation.
That's fancy.
Next. And as you mentioned, we checked the coronary artery system with invasive coronary angiogram, and we found no significant lesion. So we inserted the sheaths, 14 French sheaths first, and then we inserted we take the pictures. This is the aortogram in three-cost view. Next. This is overlap view. And we inserted the wire through the aortic valve and inserted the pigtail already. We have a pigtail in place in LV. So we're gonna insert safari wire.
좀 하나 더 풀어줘. 내가 빼줄게. 풀어라. 밸브 주세요.
So we already inspected the delivery system, and the valve was well loaded. So in this case, since the valve area is about 0.9 and the calcium amount is not that high, so we will not. Will not do predilation, and we directly insert the valve. So, and in this case, since the calcium amount is not that much, so also.
Are you using an inline sheath or?
Yeah.
Yeah.
This is we are using.
Because you have 14 French.
So we inserted the delivery system with the flush port directed to 3 o'clock, and then in the low descending aorta, we check the direction of the head marker in an AP view, and as you can see, the head marker is directed to left side, and we LAO 주세요. As we go further upward, we try to keep the direction of the head marker toward the greater curvature. So now, sometimes
위로 뺐다가 좋았어. 천천히. 좋았어. 좋았어.
Yeah, now the head marker is directed to the great curvature. And okay.
테일을 다시 뺐다가
So
다시 좀 맞추죠. 더 빼. 완전히 뺐다. 그리고 올려.
스리커스 뷰 보여주세요. 줌 넣고. 줌. 스리커스 뷰. So we check the axis of delivery system in three-cost view projection, and then we're okay. So you can see the markers of the valve. As you can see, 3 dots. So it has 1 to 1 to 1 to 1 position. So and we'll go to the cusp overlap view. So RAO view. So we check. We see the head marker is located in center front. So this is good for the alignment. And also, we may see the C-tab directed to the left side. So this should be the right the commissural alignment.
All right. Go ahead.
So I will insert the valve. So
약간 코달자.
코달 좀만 주세요. Okay. Yeah. So we'll start here.
This is cursive overlap view, right?
Yes, yes.
Okay.
Okay.
Yeah. So pacing 120 beats per minute. Okay. Yeah.
This is FX. Yes. US default is FX first. Well, big. Yeah.
Dots.
Okay. Test.
괜찮아.
It's okay.
꽉 잡고 있어줘.
Can okay. 자, 앵글 좀 맞춰주세요. 마커 좀. LAO 좀만 주세요. 오케이. 자, 센터 맞추고 에어토그램 한번 찍어볼게요. 에어토그램.
아우.
Shallow.
A little bit shallow.
Okay.
Too high.
We go a little bit
Too high.
deeper. So
This is LA view.
다시.
LAO.
네,
Yeah.
네.
Okay.
So where do you think of commercial alignment?
오케이. 네, 여기서 가죠. 네. 혈압도 안 났습니다. 알았죠. 좀만 더 보세요. 오케이.
자,
Yeah. So aortogram again. So how about this?
I think it's much better.
Yeah. So I think it's
I like
okay.
it.
We go to LAO. 트리커스피로 갈까요? Yeah. Okay.
좋아.
aortogram 다시. Yeah. Yeah, and the depth at LCC is also
I like it.
okay. So I think it is good position.
가자.
Yeah.
천천히 할게요.
Slowly. 천천히. 네. 천천히 가세요. 천천히. 멋있어. Okay. Save. So the valve is released.
천천히 하자.
줌 해주세요. 줌.
Perfect.
Dr. Cole, you always pacing all the way for full deployment.
Pacing off.
Actually, we can stop the pacing.
It's 120.
But I was concentrating. Okay. Recapture. 와이어 좀 잡으세요. So recapture.
So how did you utilize eyes catheter? Did you check some membrane septum or something?
얼마였지?
I think so.
membrane septum length. 가르쳐 주세요. Let me check.
Okay, so I usually use eyes catheter for the interaction between membrane septum and the lower end of the oblique valve. And currently we are using 40 eyes catheter by Siemens. And if we used to use 2D, I put some PL flex and rotate clockwise and put the catheter in the right ventricle to visualize membrane septum.
When we start these cases, we start the coronary access issue. So I'd like to ask how many percentage of the PCI after the valve TAVR procedure after the 6 months? I'd like to ask what is the percentage of the PCI in the Asan Medical Center and Dr. Hayashida or the other lab? Actually, in our center, we did the 1,000 cases. Among the 1,000 of TAVR, 600 was by the Eberhard, and 400 of is a Sapien. And among those cases, we did the PCI before or during a TAVR is 140 patient. It means actually 15% of the patient need a PCI. However, after the 6 months later, actual incidence of the PCI is only 10 patient. It means that the 1% of the patient need the additional PCI after the 6 months.
Rotation. Okay.
So I
So
totally
we'll check.
Go ahead.
Yeah, we'll check the whether we will do rotational fluoroscopy and to check the whether the valve is systematically expanded. So in our opinion, the valve is fully expanded, and we'll also check the cardiac echo. Can you see the eyes image? Okay, this is the longitudinal view. In this view, we don't see significant palpable leak, and we'll go to short axis.
Great. Very perfect. 29, 17%.
Yeah, this is the short axis view, and here we don't see significant probable leak.
약간 위로죠.
I think it's perfect.
So, do you think we need post dilation in this case?
Did you check the gradient already?
Yeah, I didn't see a gradient, so that would be how I would.
Yeah, yeah, we'll check
We will
that.
check it.
That
We
doesn't
will
look like you
check-
need
and
it,
then we
but
also-
I would check it, yeah.
My prediction is you won't,
Yeah.
but
It's well expanded.
it's a pretty big evolute,
And not much calcium, not very much calcium.
but I think
When you see the eyes finding and the shape of a valve is almost be not perfect circular, but almost be circular. Why the shape of circular is important is that well, just look at the valve itself. What I mean is optimal coaptation is a 3 valve is important. When the valve is deployed in the elliptical shape, did you imagine then the coaptation is the excellent asymmetrical? The valve shape is the maybe resulting in the suboptimal valve coaptation, and may be associated with the accelerate the valve degeneration. Therefore, we would like to confirm it in the on-site. That is the value of the eyes.
Yeah, on this projection, this is the cusp overlap view projection. So you can see the markers, the valve markers, 3 dots, have 2-to-1 formation. And also the C-tap is directed to the left side. And I think this is ideal formation of the conventional alignment. So,
제로인
제로인
저거
한번
좀
볼까요?
헤모다이나믹을 좀 보여주십시오. 스크린에 좀 띄워주세요.
다시 한번 할게요.
Perfect. Do AR.
오케이.
자, 빨리 보여주십시오.
Yeah, this is the hemodynamics. The LVDP is about 25, and there is no significant pressure gradient.
yeah, I don't see any concerns here. AR index is
And the
okay.
ECG, as you
This
can
way,
see
Dr. Cohen,
here,
so would you, is there any difference between the previous Evolute R and just a new version in Evolute, Apex,
Yeah.
something like that? What's the
This
advantage?
system has, this system, the FX system has these markers, and I think it helps a lot for us to have a better conventional alignment, and also for the control of the implantation depth. I think it is very helpful to have these markers. So, and also for the, it is my subject opinion, but the valve after implantation, I think the valves centralize better than previous system. And also the flexibility of the system is also improved. So in general, I think it has a definitely better system than previous one. Yeah.
It's really good cases.
So I have a simple question, and this case is relatively not complex, and the calcium amount is not huge. So in your center, Severance Hospital, 60% use Evolute system, remaining 40 systems are fan valve. So you are, I'm looking at the first case, very severe calcium because the valve, like a calcium burden more than 104,000. And what is your preference in your center? Do you still prefer the Evolute system rather than Sapien, or the reason why? How about your opinion?
Yeah, so we don't prefer specific company or valve system, but we check, the importance of, we know the importance of coronary access, and also when we have patients with higher risk of complete IV block, then definitely balloon expanded valve has advantage. And however, in the patients with high amount of calcium, then it does not happen often, but still the risk of rupture is there. So we have to be more careful. So in such cases, then we prefer self-expanding system.
Generally, simple lesion for the sapien,
So,
complex lesion, and the self-expandable. That is we covered 60% is a high-risk patient.
so would you gonna do aortogram? No?
Yes,
we'll do it.
yes,
No
of course.
contrast anymore?
Actually, based on the ice finding, if you want that,
aortogram, please.
we will finish these cases. We are so happy.
Good.
Okay, so
Too close.
aortogram.
It's okay.
I
It's
think
okay.
Yeah.
This
Okay.
We try to the more cross.
You're gonna make an artificial. All right, perfect.
Yeah. So what do you say?
All right. Any other comment on the about?
Well, no, I mean, everything,
I have a question, sorry.
everything's been said. I think that's an excellent presentation of how we do it, state-of-the-art deployment of this particular valve. The beauty here is what they've shown very nicely. They don't dive into the ventricle and pull back. Let the
Anyways.
valve go down. So, obviously less conduction disturbances, less pacemaker rates. And I think the ice, the ice is an interesting variation, particularly in elderly patients with impaired renal function. In all, it's what we're used to see in Severance. Excellent team and excellent deployment.
Okay. Anyway, finally, angel actually, position-wise is perfect. Would you show us the angiogram? All right, so I would like Dr. Hong, what do you think the, really 3 dot, due marker, is it really helpful for the placement of a device or?
Compared
Do you
to the
think so?
previous version, 3 marker is the helpful for the
All right.
more the better placement of the valve. That is clear. It's 100% of the satisfaction. Actually, it is not, but anyhow.
I think it helps
It's
with
a
the,
more,
more
beneficial.
with the commissural alignment than the depth.
Okay, really thank you for a nice case demonstration and thank you for joining us. Dr. Go and second operator, Dr. Hong. Really, you look young.
Thank you.
All right, thank you. All right, Charles, you want to move to the, Seoul National University Hospital cases. Before that, I would invite Hyo-Soo Kim is here. I didn't realize that one. Come on the stage.
한정규 교수님, 김효수 교수님이 앞에 오셔가지고 직접 좌장석으로 이제 오셨습니다.
Hyo-Soo Kim is here, Dr. Han. All right, you have to do, how do you do? Your boss.
Thank you for inviting Dr. Kim to the stage. So, let me introduce our team today. I am Dr. Jung-Kyu Han. Welcome to the SNU Hospital. We have a second operator, Dr. Jeehoon Kang, and we also have our clinical fellow, Dr. Jin-Won Song, and we also have Mr. Young-Min Kim, who is a radiologist technologist. So I'm going to present today's case. 슬라이드 보이세요? This patient is an 86-year-old female patient, and she has a small build. BMI is just 16, And she was admitted for the acute decompensated heart failure management last month, and pneumonia was combined, and now she was readmitted for the TAVR. Next. She has diabetes, hypertension, and dyslipidemia, and has rheumatoid arthritis and chronic lung disease. Next. She's taking several drugs, including antidiabetics, and she has very severe aortic stenosis. Next. STS score was calculated to be 13%, mainly because of several comorbidities, including chronic lung disease and chronic usage of steroid. Next. Chest PA in the left side shows the chronic lung disease as a baseline, and in the middle you see the pulmonary edema during the last admission, and right side you can see the pulmonary edema was improved. Next. EKG shows the sinus rhythm, but there's LVH and LI enlargement and QT prolongation. Next. Echocardiography shows the LVH, so there's some risk of over migration during implantation of self-expandable valve. And she has a very severe aortic stenosis. LV ejection fraction is 50%. Next. So AVA is 0.4 and Vmax 5.2, and mean pressure gradient is higher than 60. So this patient has a very severe aortic stenosis. Next. CT angiogram, coronary angiogram shows intermediate region with some calcified plaques. Next. And there's no severe tortuosity or calcification through the femoral access route. Next. The diameter of the femoral access route is good. Next. Next. The calcium volume calculated on the contrast view is higher than 600 cubic millimeters. Next. And in the non-contrast view, Augustin score was higher than 3,000, and the calcium volume calculated on the non-contrast view is higher than 2,000. So this patient has heavily calcified leaflets. Next. And there's some calcium nodule extending to the alveoli on the left side. And annulus and LVT size is 21.9 millimeters. Next, small annulus. And sinus valsalva is good enough, ranging from 26 to 30, and acid junction diameter is 26. Next. Coronary height is higher than 10 millimeters, and acid junction height is higher than 18 millimeters. So there's a low risk of the coronary obstruction. Next. Membrane septum length is 5.7. Which is good for in the Korean, because usually we see less than 5 millimeters in Korean population. So although this patient has a small build, but the membrane septum length is good enough. Next. 3-cos coplanar view was also seen to LAO 12 and caudal 1 after aortography, and cos overlap view is RAO 13, caudal 28. Next. So this patient has a small annulus, less than 430 cubic millimeters, and the annulus size is 22 millimeters, small annulus. And we are going to implant a diameter valve in this patient, and originally the pre-dilatation balloon size should be match the minor axis of the annulus, which is 19 millimeters, but in our experience it is too small to get good expansion, especially in patients with heavily calcified leaflets. So in our institute, we usually take a bigger size of balloon, matching the perimeter-derived diameter -1. So in this case, we will take a 21 millimeter balloon for the pre-dilatation, and if needed, we will take a 22 millimeter balloon for the post-dilatation. And I think there's a high probability of post-dilatation because this patient has heavily calcified leaflets. Next. So we don't want to place the intra-annular balloon expandable valve in the patient with the small annulus. Next. And if we take Avalon system, 29 millimeter Avalon gives us a 23 millimeter oversize index, which is too big. And if we take a 26 millimeter Avalon valve, it'll give us a 10% oversize into small. Next. So we selected a Navigator Vision 25 millimeters, giving us a 13% of oversize index, which is good. Next. So basically, this patient has high-risk clinical features for the procedure, and TAVR in the small annulus, and the patient has a heavily calcified aortic stenosis extending to alveoli with very severe aortic stenosis. So you will see the performance of Navigator valve in these high-risk patients. Next. As we all know, Navigator valve is an intra-annular structure, the self-expandable valve, and it has a large cell design, giving us a good reaccessibility after the valve implantation. Next. And there's active cell, which is especially important to reduce the risk of PVR in patients with calcium nodule, like this patient. Next. And comparing with the Sapien system, several registry shows that Navitor has a bigger size of effective orifice area, even though it's also intra-annular structure. So we selected this valve in this small annulus patient. Next. For the Navitor, we can try commercial alignment, although it's not indicated by IFU. For that purpose, we use the CT angiogram, and first we mark some dots through the midline of the aorta, and then we stretch the aorta, and we mark 3 dots corresponding to the commissures at the level of annulus, and pull all 3 dots to the descending aorta. And then next, we bend back the aorta and rotate the aorta to get 1-2 and 2-1 configuration of 3 dots. In this case, LAO 23 and cranial 18 give us 1-2 configuration. LAO 39, cranial 19 give us a 2-1 configuration. Using these 2 configuration, we can make a good alignment at the level of descending aorta. And then we need to keep the orientation of delivery castet during hold-up procedure, which is sometimes not very easy, but we can try. Next. So as you can see on the left side, we make a 1-2 configuration, and we confirm the configuration at the different angle, 2-1 configuration. So using this relationship, we can make a good alignment. Next. So this is the final result. In the silicon coplanar, we see this 1-1-1 and cost overview 2-1 configuration, which is a good alignment, and we'll try it in this case. So that's it. Next is 끝이죠. 네. So because we only have about 20 minutes, so I'm gonna start my procedure now. Reference 내려주시고요. So we place the sentinel device in this high-risk patient, and then cross the aortic valve. We check the silicus view. This is silicus coplanar view, adjusted, and this is this is overlap view. And then we place we cross the aortic valve using the straight wire, and we have inspected the valve system. So this is the progress until now. The pivotal catheter is located in the LV, and then I'm going to replace place the safari wire. 이거 좀 잡아주세요, 영민 씨.
Okay, wonderful presentation.
아래로.
Dr. Han, please go ahead. We are going to discuss your case. I think this is really high-risk patients, 86-year-old female with very small body size.
Okay.
Even a further important factor is BMI is less than about 18. Just recovered decompensated heart failure. This is really high-risk patients with heavy calcification, small annulus. Thus, they select a safer self-expandable valve such as Navitor. Is there any comment from the panelists?
I don't have any experience with Navitor, so I only learned what I read in books. So I'm very interested to see how it works here, and if you could do the commissural alignment, I think that will be.
I think this is a very good example where you should be, actually in my opinion, where you should be using a self-expandable valve and not a sapien, if you have a choice. Because here you have calcification, heavy calcification, small annulus, calcification extending in the outflow tract. So all these criteria are for the Navitor. I think it's a very, very interesting choice. And we're eager to see what the results are.
The most important difference between Navitor and Evolute is expansile force. This opening force is very weak. Thus, we always do a pre-ballooning. Now he chose about 20 millimeter balloon to just separate the adhered calcified valve leaflet, then implant valve. That is a very important difference between two systems in procedure. Always.
So, Dr. Kim, do you think it is pre-dilatation is one thing, but do you actually recoil after that because of the somewhat weaker, force?
I think certainly in the U.S., we're often think if it's a very heavily calcified valve, we should not use the Navitor so much. That the Evolute would be a
perhaps a better
So
choice,
that-
but
that-
that's the
that will-
question.
When you,
Yeah.
I mean, you're not using self-expandable valves, so what would you be approach in this high-risk group with a sapien? What would be different from your regular procedure?
Were
Using
you asking?
a sapien?
You're asking Dr.
아래 좀
Yeah,
AP
I'm
아래 좀
Duk-Woo.
보여줘야 돼.
W.
Yeah,
so,
How would you do this with a sapien?
Yeah. I think this case is not much difficult. The sapien is very fast, and without predilation,
So-
I can do is very rapid deployment procedure for such case.
Now I'm going to try to get a good alignment at the descending level. 1 to 2 configuration, a layer 32, cranial 12. We should make a 1 to 2 configuration. Here, you see?
Yeah.
And then 저장하시고 아래 28, cranial 6. You should see the 2 to 1 configuration at the level of descending aorta. So one limitation of this valve and also Eberhard is we need to make a alignment at the descending aorta basically, and then we should keep the orientation of the casta during the whole procedure. 디스 각도 유지하시고. 자, 엘레이어 주세요. 엘레이어 30도. 잘 유지하고 잡아줘요. 어떻게?
So you just keep it in the same orientation as you advance?
Yes.
But the actual situation is it rotate a little bit.
저장해 주시고.
Thus, even though we
And
adjust
아래 코드 저 overview.
commissure at descending aorta, when we see its commissure alignment and annulus area with cusp of left view, it should not be always 2 to 1.
Yes.
Thus, that
this
is a kind of limitation of navigator system.
Yeah. This is covers overview. There's some mismatch, but almost 2 to 1 configuration in this view, giving us a acceptable alignment. So now I'm starting the deployment.
Dr. Han, please try to rotate a little bit. If it's very difficult.
It doesn't always work because this valve has very flexible caster, so rotation at this level doesn't work very well. I can try it. Minor final adjustment can be done, but torque delivery is not good.
Usually,
But the strength of this valve is
commercial alignment is usually done in the descending aorta. Yeah.
Yes.
Because torque
As
delivery
like
is
the
very
Eberhard.
difficult if the
This
valve
valve has
post
very
arch.
very soft delivery system that's good for this valve, but there's also always a trade-off. So I'm gonna start the deployment. 오케이, 120회 시작할게요. 조금 이따 시작할게요. 자, deploy. I'm usually start at this level. Deploy.
It is crimped status. That's, the 2 dots are close to each other, but if it expands, the distance separated. That's
Stop 저장.
then
This is cusp overlap now, right? This view?
yeah, cusp of the view.
I'm doing control the pacing test.
Is 120 control?
Test.
Probably.
테스트. 자, 그만. 자, deploy.
The marker depth is from 3 to 4.5 millimeter from the bottom. The marker height is about 1.5. The lower point of marker is 3.
I'm gonna check the left
4.5.
side LA view
Looks
to confirm the depth at the left side.
This opening force is relatively
Test.
weaker than the
Yeah.
Eberhard system.
Depth is very nice. 자, 다시 overview. And I'm resuming the deployment here. Deploy test. Deploy.
Dr. Kinney, is that your routine to change the angle during not yet fully touching the
Pacing off.
Yes, always there is a parallax between the annulus plane and valve plane. Whereas at the initial point, we just adjust annulus plane. But
여기서 맞춰보세요.
during inflation, the valve is a
There's
little
a
bit
huge,
oblique. That's in that case, we adjust a valve. 3 markers
AP
as
사이드
one
쪽으로
single
가야지
plane.
코드를 더 갈 수 있을 거예요.
Dr. Kim,
AP
I have
side.
a question. The navigator THP is the pre-ballooning is the, mandatory, right?
Yeah.
How do you decide the
LA로
size
좀 가세요.
in case of just a short diameter or the mean diameter or?
Initially, a manufacturer recommend
코드를
the shortest diameter.
yeah.
But nowadays, they actual practice, they just adopt a balloon
too
just
shallow.
1 millimeter less than median diameter,
LA가 35도.
1 millimeter
less
less
than mean diameter,
mean diameter.
more aggressive.
The reason why the bigger than the short diameter, why the opening pores were
A better opening force.
다시 앞과 꼭 들어갈게요.
There is
13에서
no
14도.
concern about the safety, even though we chose balloon whose diameter is 1 millimeter less than mean diameter.
I will do recapture now because there's huge device parallax. So we adjusted angle. So I'm gonna implant at this angle. So 자, recapture 반대 방향으로. Recapture.
So we also experienced more than 10 cases Nabito. I think a parallax much problem rather than Eberhard system. Yeah.
Because the shaft is softer.
오케이. 저장하시고. 요 각도에서 yes, at this angle I'm gonna implant, deploy, 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 deploy 좀 더 빨리, deploy, 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 stop. 자, test.
Kentaro, and you have also many experience Nabito case. Do you frequently use distal inflation technique?
So we usually use distal inflation technique to open up the distal part of the navigator inside of the ventricle to avoid non-uniform expansion. For this case, we observe some non-uniform expansion that may lead to the unexpected upward motion of the valve. So if you do that too much, you might cause a conduction disturbance, so we should be careful.
Test.
This softer expansile force leads to non-uniform expansion of the valve leaflet frame, because usually shaft is caught between the NC and RC commissure. If there is heavy calcification, that part valve frame does not expand well. As non-uniform expansion occurs, which may induce a sudden movement during the final release process. Thus, we have to avoid non-uniform expansion. But nowadays, most as experience accumulate, non-uniform expansion is not so important factor, as we don't use distal implantation technique nowadays.
Test. Okay. Deploy. Deploy, 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 test, deploy, 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 deploy.
The manufacturer recommend very high implantation, just 3 millimeter ventricular depth. Thus, actually, we more frequently capture when we use Nabito less than the Eberhard.
More recapture.
Is it too deep?
Because they
more Navitor?
More than Eberhard. Because they recommend a very shallow implantation depth, so we always try to adjust.
Soft catheter also, just like a balloon, hence makes it go up and down a little bit more, side up and down, rather than staying put. So it's a little trickier to deploy it well.
This looks like a good depth, I think, here.
The beauty is this is intra-annular design, thus it is better when we perform a TAVI and TAVI in future.
It's somewhat deep, but the half cell height is 7 millimeters. So I think it's acceptable. 아래 포달 뷰 주세요. 오버랩 뷰.
About 6 millimeter, about 6 millimeter ventricular.
So do you have any conduction disturbance at this moment?
No.
No. 포달로 가시고.
Considering a tendency of a slight distal movement during the final release, I think this step is wonderful.
The NCC side is good, and LCC side is about 7 millimeters, and left side on the screen, you see about the 3 millimeter depths, 3 to 4 millimeter depths. So I think it's good enough. What do you think?
I think the LVOT size is a little bit smaller than annular size, near to each other, but smaller. Thus, that may exert a little bit distal movement of the valve frame during the final release, as we always see. Thus, I think this depth would be acceptable and good because there is
And
no conduction disturbance.
Yeah.
Yes, and we need to wait for 2 minutes after the first deployment procedure. During these 2 minutes, we check the valve depth, and we already did it. And nitinol is exposed to the body temperature, and then it hardens during this 2-minute waiting because it's a cell-shape memory alloy. And if it's exposed to body temperature, it gets hardens. So we'll get more radial strength during this 2-minute waiting. And after the final deployment, we'll see some modification of the angle. Then the depth will be somewhat changed. So LCC side tends to be deeper, and the LCC side tends to be shallow after final deployment. And during the final deployment, we should gently push the valve because we usually see over the migration of the valve, especially in this patient has a LVH, so there's some risk of over the migration. So I'm gonna start the final deployment procedure. First, we pull back the sapphire wire, and then 자 갈게요. deploy 여기서 할게요. deploy. Yeah, gently pushing the caster. Okay, stop. 저장.
It is
This is
important
the
to
no
withdraw
return
the
zone.
wire.
And then we usually rotate one full rotation of the field, and then wait for 5 seconds. Deploy. Because we usually see the popping up motion of the valve during the final deployment procedure in this valve. I think we will see some popping motion after the one rotation. Next rotation. Okay. This happens. 저장해 주세요. 자, 끝까지 갑시다. deploy. 끝까지. Okay. And then 여기 좀 okay. 살살 뺄게.
Do you think that valve is still a little bit constrained by the external calcification?
Yeah.
Yeah, I think so.
It
Yeah.
requires the
자,
post-ballooning.
AP.
You always post-dilate this valve?
More than half.
Okay.
More than half.
갑시다.
Because it is intra-annular design, thus when we see the eccentricity,
Okay.
not circularity, the coaptation would not be ideal.
자,
Thus, I
적어주세요.
always
테르모
recommend
주시고.
post-ballooning.
그리고 포딜 준비해 주시고.
The size of post-ballooning is usually same to the
Pre-dilation.
annulus diameter.
Annulus. So we'll take 22 millimeters in this case.
Then you're
Yeah, in this case 22 millimeter.
Okay. Die syringe. So we'll go to overlap view to check the
when you post dilate, does it
alignment and
rise
depth.
up just like the evolute a bit in terms of?
Yes, we usually
That's
some
right.
rise up around 1 millimeter. We usually see that.
So that's slightly lower, maybe better here to allow it to rise up a little bit.
Okay, 아래로 코달 조금 더 가볼까요? So you see some auto tilting after the final deployment. 코달로 더 가야 돼. 크레니얼 가세요. 크레니얼.
Now you can see
그래,
the
좀 더,
dot.
좀 더.
It is not 2 to 1. It is 1 to 2.
됐네.
As commercial alignment is not good.
Good.
Okay. Right side on the left side on the screen depth is 4.5. LA view 35도. 거기서 맞춰보세요. 프레임. 조금 더 크레니얼로 가야 돼. 좀 더 가세요. 오케이. 네. Yeah, it's about 6 millimeter on the right side of the skin, LCC side. 아래 포달 view. So I'm gonna perform the post dilatation. 자, 갑시다. 타이머 끄세요. 시계 봐야 돼. 시스 준비하시고. 타임. 오케이.
It would be very interesting to see the reduction of regurgitation after post-ballooning. The impact of post-ballooning may be sufficient to reduce regurgitation substantially.
I think it's moderate now, right? It's 2+ probably. So hopefully the balloon will do a good job.
How is the size of post balloon? Dr. Han, the size?
22 millimeters.
22, okay.
Matching the parameter-derived diameter.
Okay, 22. Under cusp of left view.
Yes.
Why do you care what view you do the
balloon,
post ballooning?
Overlap view?
You want to make sure you do the post dilating in a cusp overlap view?
Because we can see the most underexpanded frame in the cusp of left view.
Okay. So you want to see the frame expand? Okay. Not for.
Also the higher side, so it rise up more for whatever reason. Because the left side is a little low already.
Okay, here I'm going to perform post dilatation. 페이싱 준비하시고. 페이싱.
Not pacing fast enough.
네, AP 주세요. 페이싱. We need to adjust the location of the pacing. 좀 빼줄까? 페이싱 한번 테스트 해볼까요? 100회. 스탑. 180회. 하세요. 스탑하시고 160회 해보세요. 160. 스탑. 160으로 합시다.
With the evolute, when we post dilate, we tend to want to have it be more ventricular. Is there concern here? The same with Navitor?
Okay. 160회 페이싱.
Movement is really minimal.
Okay.
That's I don't have any concern about movement of valve during post ballooning.
페이싱 오프. 오케이. 자, 와이어 스타일 빼보세요.
Bigger.
Yeah. Became bigger.
I don't want to perform any other post dilatation, so I want to replace the safari wire for the pigtail, and then perform the angiography to assess the PVR or aortic regurgitation, and show you the pressure gradient.
Blood pressure is a little low, unless that's not right.
Blood pressure is okay.
Yeah. BP, blood pressure is okay?
At about 50 to 60, I think it will be stabilized. 혈압이 좀 낮습니다. 좀 올려주세요.
Patient is very fragile, elderly female.
It's coming up. Okay. A little gradient.
자, 시내 볼게요. 다이 준비돼 있죠? 시내.
Yes, much better.
Considering heavy calcification, we can see the regurgitation is really minimal.
Silica view.
AR is good. AR is good. Is that gradient from, is that intracavature? Do you think that's I mean, she had such a small, thick ventricle.
We see some mild regurgitation, but echo 좀 봐볼게요. We'll check the pressure gradient.
Okay.
And you just pull your pigtail back a little.
Then show you the TTE echo. We see some mild regurgitation, but I'm not sure it's because of pigtail placed in the LV or PVR because of some calcium. We are not sure.
Yeah.
제로 됐어요? So the pressure gradient is gone.
That's good.
you see the echocardiography.
Yeah.
쇼덱스 한번 가볼까요? 네. 컬러 좀 한번 보세요.
Yeah. It's interesting that it just went away.
Because orifice area is wider than sapien, we implanted 27mm valve for this small body size female. I think orifice is really wide.
Should be fine.
Small amount there, yeah. Just on the posterior side.
I think hemodynamics is very good. AR index.
Yeah,
is
we
good.
see some PVR matching the calcium nodule site. I think that's the most we can, best result we can get, I guess. So I don't think we can perform the further post-dilatation to reduce that PVR. Hopefully, because this valve has active seal, then after some time, the valves, there should be some thrombosis between the calcified nodule and PVR will be reduced, hopefully. Then we'll check, we'll follow up that using the echocardiography. And then...
is that commissure is between left and non?
Yes.
Okay. So remove
I'm
the
taking
ventricular,
out the
remove the ventricular catheter and final
and
angiogram.
then check the angiogram. 자, 아래요, overlap view. 약간 맞춰보세요. 더 코달로 가야 될 거나.
The most important hurdle for Navitor to improve is the commissure alignment. We try to every effort, but it is really random. So it is impossible to adjust commissure.
자, 3-cos view.
So it's definitely better. The AR is less than before the post-dilation, for sure.
네. 좀 코달로 가세요. 오케이, 됐어.
It's clearly, yeah, it's not bad.
Okay, so that's it.
Okay, is there any final comment from the panels? Okay.
I think it's a nice demonstration of using it, but also some of the challenges with it. I think, as you alluded to, the cusp overlap is tricky. So that's something to work on.
In these really heavily calcified valves, I'm not quite sure all three valves would not have some PVL, I think, right? Because when you have a big piece of calcium, there's always some crack there that you can't really do very much to. So that's one of the limitations, even with the sealed and so forth, but they cannot get into the crevice.
And one of the interesting things about the Navitor is it does have, it has lower gradients than with the Sapien, even though they're both intraannular. So it's not just the superannular, it's something about self-expanding that gives you the low gradients.
So especially these patients are calcified nodule, so that's nice for the PVR.
Yeah.
And hopefully active seal works in the next follow-up echocardiography.
Great.
Okay, wonderful demonstration, Dr. Han, Dr. Kang. Congratulations on your live demonstration.
We'll switch to our opening session. Let's play the video. Yeah.
Lectures on?
I'd like to welcome Professor Seung-Jung Park to the stage to give us our opening remarks for the 2025 Seoul Valve. SJ.
Good morning. Actually, we're still. Good morning, everyone. Welcome to 14th Seoul Valve 2025, and thank you for joining us today. As you may know, this year marks an exciting new chapter for our meeting. After nearly a decade as AP Valves and Structural Heart, we are proud to move forward another new name, Seoul Valves. These brand new changes not only reflect where our journey first began, but also signals our renowned commitment to advancing the field of structural heart intervention. Each edition of Seoul Valves will spotlight a focused theme. For these years, we are highlighting complex TAVR and valve-in-valve procedures, two of most rapidly evolving areas in our field today. Over the next 2 days, we will present 13 live cases from the 7 leading centers across Korea, China, Hong Kong, and Taiwan. This live demonstration will provide practical insight and key takeaways from top operators worldwide. In addition, our lecture session will cover a wide range of hot topics, including TAVR, valve-in-valve, bicuspid, tricuspid, tears, and pure AR, and more. So we invited you to make the most of your time here by sharing your thoughts, asking questions, and connecting with colleagues. I hope your experience at this meeting will be both meaningful and memorable. Thank you again for joining us today. Right.
Great, SJ, why don't you just obviously stay and give us the feature lecture. The title is 15 Years Journey in TAVR at Asan Medical Center.
Thank you. So I just briefly reviewed our experience about the TAVR procedures. If you look at the current status, but still, guideline from the 2020, 2021 in ESC, they separate with the age 65, the meaning age, expected life, expectancy more than 20 years, less than 65, safer still, class 1, unsure for TAVRs. However, in almost all patients as more than 65, TAVR would be indicated. 24, and not too much changes. They separated less than 75. However, TAVR would be class 1. Look at this national trend TAVRs. Many patients, if you look at 65, 80 years old, getting increase TAVR procedure, decrease severe, just 12.5% is very small. However, in case of, look at this, less than 65, relatively young patient group, the TAVR is almost 50. Half of the patients, receive TAVRs. So, if you look at the TAVR trials, getting more low SDS scores, younger ages, recent published dedicated trials, SDS score 1.8, right? So mean age is 74, transfemoral TAVRs, balloon expandable 61%. Actually, the TAVR procedure is clearly statistically is better than the SEVER. The meta-analysis, all deaths, cardiovascular deaths is favored TAVR, and we don't, we can say that TAVR is better even in low-risk aortic stenosis patient. So TAVR moved to the low-risk and young patients. Actually, we started TAVR procedure 2010 under the Proctor Switzerland Cribier as a practical guideline in our hospital. Severe symptomatic AS, all age more than 65. Anyways, we do, would be the first choice of TAVR, saver for only unsuitable TAVR. However, we have very active heart team collaborations. We performed 2,289 cases up to this point, getting increased cases. Look at this, to believe or not to believe, procedural success rate 99.5%. It's almost perfect. Coronary obstruction just 0.2%, permanent pacemaker 9%, etc. So what's difference actually, right? There is our team in Asan Medical's heart team collaboration, minimalist approaches, and CT algorithm for device selection. Very important part of CT. In the later we will discuss about that. Heart team actually don't say anymore. The smart cardiac surgeon send the patient with aortic stenosis to the interventional cardiologist. For TAVR, so we don't discuss anymore. Minimalist approach, no general anesthesia, no more transesophageal echoes, one day stay in CCU, discharge on 3 days, actually very simplified all the procedure. It took just 20 minutes, from the beginning to the finish. CT algorithm concern, I would, focus on the most important part of meticulous CT analysis. As many, all the centers, actually they encourage the CT algorithm, CT analysis before the TAVR procedure, vascular access, annular size, and ST junction, sinus valsalva, height, calcium amount, distribution, and finally, device selection for the CT, analysis is femoral artery size, how big it is, annular view, annulus size, parameters in terms of diameters, area, perimeters. We measured that. It's some study defined, area less than 430 is smaller. They defined the smaller annulus in a smart trial. Anyways, we measured in terms of a ratio, relative area ratio of sinus valsalva, ST junction, LVOT. It's quite easier to perceive how big be sinus valsalva, ST junction, LVOT here. So look at this. We area ratio in our labs, we mean ST junction, valsalva. 1.8 is mean ratios, and if the case is 1.9, it is relatively big, sinus, rather than we expected. ST junctions, we have some, mean value, coronary height from the left side. At least more than 10. We, measured calcium amount and locations, how much in different, non-coronary, right coronary, left coronary, and extended LVOT extensions. So actually calcium is a major, determinant in terms of procedural outcome of TAVRs. Exactly same manner, just Eberhard, our cases from the Severance hospital, the calcium amount, I just remember the 403 something, and however, Seoul National University, the case is a very high severe calcium. And finally, whatever you use, the self-expanding PBL, in a case of a PBL, in a case of perfect, right? Result over there. And so calcium, moderate severe PBL, permanent pacemaker, or both is mainly influence the amount of calcium. And so as a 3 device, balloon expandable device, we do mainly depending on the calcium amount, mild, moderate, severe. We have an artificial cutoff value is 400 something. So we can use area of size in case of mild calcification is a cutoff of 10%. In any way, bicuspid, heavy calcification, the first case Dr. Ahn actually show us about that one. We used the SAPIEN, 0% is area of size, even less than that. That is our rule. So in case of a balloon expandable, we made a very discrete device sizing. Using the 23, we're going to make a 22, 24, and 1 millimeter size. We're going to make a small size of. However, in a balloon self-expanding, actually they limited size 23. and 27 something. So I would, look at this. We apply all the analytic information obtained from the city, scan to the upcoming procedure, right? Left coronary cusp high 10 and right coronary, it's quite good. However, very heavy calcification, long left coronary cusp rather than we expected, and very small sinus valsalva ratio, 1.6, and actually mean is 1.9. The meaning is, anyway, sinus valsalva is very small, heavy calcification, more than 1,000. Actually, what do you think? It's a high risk of coronary obstruction, so we have to consider coronary protection, the small size device in terms of area of sizing less than 0% or less, pre-dilation with a small size balloon, and what about the self-expanding for particular this case, or if possible, so you want to send the patient to the surgery. So in our lab, we prefer balloon expandables, actually. So I want to briefly review what are the difference. You know that cobalt chromium frame and retinal frame. Main difference is radial force, right? Look at this. If you look at the radial force, circumferential compression and for the resistance and crush compression, if you look at it, this is all the data. This is balloon expandable sapien, and that would be the self-expandable, including the accurate nails. Anyway, they disappeared. Very low radial force for that. And so if the concept of circularizations of annulus, balloon expandable, 86% circular, and self-expanding 50% circular. The meaning is that in case balloon expandable, strong radial force can make a device remodeling the annulus in circulation would be good. However, in self-expanding, so weak radial force, the annulus remodeling the device. So that is a kind of a malopposition. If you look at the area of caudal view, even in depending on radial force. If we learn from the accurate IDEA trials, you know that valve under expansion more than 20%. Actually, it may be even higher in real world practice. There is a randomized study, and so the under expansion required a little bit higher frequency associated with a composite endpoint, death, stroke, hospitalization, and associated with the heart endpoint, death and stroke is clearly high in those groups. The reason primary cause under expansion is valves low radial force and severe calcification. Don't worry about physicians or worry about root ruptures. That is our experience. Just 2 cases out of 2,000 sapien, 0.1%. However, under expansion related heart endpoint concern is more than 25%. Right? Look at this. Seen in PBL, even accurate level, accurate IDA data, 1 year follow-up data is higher PBL. Political, that just previous one Navitor, device is still higher. Permanent pacemaker rate is getting better, however, still higher. And this is registry data, have a matched cohort. A little bit worry about, all-cause mortality, cardiac mortality is a little bit higher in a good self-expanding. So, all right, there is our data. Mean age 81, STS score 5.6, very low. However, I think it's intermediate, coronary artery disease, combined 38% normal ejection fractions, getting younger patient and low STS scores. Over the period, the procedural success rate 99.5%. I'm very proud of it. Surgery, obstruction 0.2%, permanent pacemaker 9% is not too much, changes from the beginning of our experience. PBL 2.5%, very low incidence. Vascular complication, 4.2%. 1.4% 30 days mortality, cardiac death just only 1%, disabling stroke 0.5% is very low, and bleeding, fatal bleeding is just 2.9%, and so mortality is not too much changes, and major stroke is not too much changes according to age, time. The 30 days outcome TAVR, Bach classifications, definition of a standard performance is really better outcomes. In case of minimalist approach, is getting better in terms of mortality, disabling stroke, any index. 1 year outcome, death 9.6%, cardiac death 6.9%, stroke 5.5%. So. All right, just briefly, bicuspid, Dr. Ahn actually get a hold, a meta-analysis, 12,000 patients. We clearly see that PBL, moderate PBL, a little bit higher, the aortic root injury, it will be higher in case of bicuspid. There is a high surgical group, they don't want to touch surgeries, we're going to do TAVR, and depending on aortic root, aortic root aorta passage, root ascending aorta size is more than 5.5, we do, consider FFR. So up to this point, bicuspid TAVR is 217 cases. If you look at the age, relatively young proportions in case of bicuspid aortic stenosis. If you look at the calcium amount, mean 670, it's quite higher, almost 2 times higher as in case of a tricuspid, 380. And type 1 is the most frequent in our cases in our hospital. We favor Sapien 3 for even in the bicuspid. The number is relatively small, however, propensity match, analysis actually not too much difference between the two. The high calcium, we need a pre-balloon valvuloplasty, and also just look like this is a post-balloon angioplasty to be a little bit higher. And matched case mortality, stroke hard endpoint, actually we didn't find any difference, bicuspid TAVR and tricuspid TAVR. TAVR is primary treatment for symptomatic AS. SAVR is reserved for the patient unsuitable for TAVR. Procedural outcomes are excellent, so we prefer balloon expandable valves. We believe that pre-procedural comprehensive CT analysis is the most important step to achieve good clinical outcome. Thank you.
Yeah, so thank you very much, SJ. And now we're coming to Dr. Alan Young. He's talking about expectations for the next 2 decades. Alan, thank you for being here.
Yeah. So when I got this title for a talk, and I said, well, 2 decades, 20 years, that's a long time. And I think there's only 2 things for certain that I think I can say that by that point, I probably had a TAVR myself. And number 2 is that, you guys will not remember what I said today because there's no way to prove it. So I can say whatever I want today without any sort of constraint. So I just want to review that in 20 years, what we have accomplished in interventional cardiology. For example, in drug-eluting stents, going back in 2002, that's the first Cypher DS, in Europe, and 2003 in the US. So really over that time, we have gotten thinner struts, and we tried bioabsorbable polymer coating, and then we have approval of that and withdrawal of the BVS. And essentially, the technology, I would say, has sort of pretty much matured in about 18 years because the lowest ISR rate now is really pretty much standard. And also, most of the trouble occurs early. So therefore, once you have a drug-eluting stent for a few years, there's really not a whole lot of significant deterioration because the stent is absorbed into the arterial wall, and you don't really have a whole lot of late events, which is very different in the TAVR field, right? Because if we look back again, 2002 when Alan Grube did his first procedure. And then essentially after that, we're using a similar valve platform and similar valve tissue, even with the Resilia tissue. It's pretty much the same, except we're just proving that this technology is feasible in clinically in operal patients, in high-risk patients, in intermediate-risk patients, essentially expanding the indication rather than looking at the technology of the TAVR itself. So again, I would say that at this point in 2025, technology is not mature. So since many issues remains, because as the valve ages, lots of issue happens for our patient. So the first order of business is that, well, 20 years, what I'm going to do is I'm going to type that into JetGPT and say, what should we expect in TAVR in 2045? So this is what is built out pretty quickly, is that there will be next generation valve designs. Well, thank you very much. And that's durable bioengineering valves, focused on the leaflets. And the valve durability will have to be around 30 to 40 years, meaning that when you have one valve, it will last the lifetime of the patient. Smaller profile. And there might be some 3D printing customization for that particular patient. So you would design a valve, put in the data, put in the measurements, and then you have a valve printed for that patient. I think SJ just talked about what he has done in Asan Medical Center. But imagine that you basically feed in the data that you just measure on CT and basically put out something at the end of the planning process and give you all the different measurements and what you should do during the procedure. So AI-guided preoperative planning. So even the field, so from the very expert to the very novice, they will actually do the procedure relatively similarly. And again, AR meaning sort of assisted reality and obviously AI intelligence, real-time procedure assistance. And there's also finally a wearable sensors to monitor valve function, so you don't have to repeat doing echoes all the time and just be able to actually measure that. So that's one way of looking at it. So I said, what else can I do? I said, well, maybe look for another oracle that can look at for the future. So Dr. Grube obviously has been talking about crystal balls, and he has done it for 1 decade. So I have to try to do it for 2 decades, which is much harder. So this is what he talked about in 2023 in Miami. And he also did a 2024, but he shortened the crystal ball. It's only 5 years now. So I think the challenge will be harder to really expand it to 20 years. But nevertheless, I borrow some of his sort of ideas and try to expand a bit on my own and think about what are some of the near-term and longer-term challenges. I think we talked about bicuspid valve a lot, and I think that's the challenge that we have to face and see how can we do all bicuspid valve. The issue with bicuspid valve we learned already pretty well is that there is some of them are relatively simple when there's no RAF-A and not a whole lot of calcium, or they have a RAF-A but not particularly calcified in the RAF-A. And then you have these terrible ones that has a calcified RAF-A and also heavy calcium as well. And as you can see from the plot down here, that if you have the third type is really calcified RAF-A and excess leaflet calcification, you have much worse outcome over time. So the question also is that if you look at these valve after it's done, many of the time we say, well, this is great, looks good. But it's actually, if you look at it carefully, there's a lot of eccentricity and under expansion of these valves, even with the balloon expandable ones. You can see there's an exaggeration here, but oftentimes if you look carefully of your valve shape after you put in a bicuspid valve, there is actually asymmetry of how this valve looks like. And actually, if you have a chance to measure it with CT, there's also eccentricity as well. So what does that mean? Actually, eccentricity and also under-expansion associate with higher mortality and complication over time in bicuspid valve as well. So therefore, the problem has to solve is not just do the procedure, but do the procedure well enough, just like similar to coronary stents, as well expansion. And the question is, one of the possibility is really modifying the valve leaflets before putting in the TAVR valve. So for example, one proposal potentially is that you actually do some of the leaflet modification of these bicuspid valve and therefore allow it to expand more symmetrically. Therefore, have better expansion ratio, less eccentricity. So how can you do that? Potentially with what we have now, potentially you could use various way electrosurgery or otherwise to create these leaflets that can actually split and allow you to have a better expansion. For example, a shortcut, which is obviously recently approved, and you can use this to modify really even heavily calcified leaflets. So potentially cutting through 8 millimeter here of obviously a cadaver valve, and it can cut through that spot. This seems to be a very good technology potentially, but unfortunately in the US it's still extremely expensive. It's $16,000 for each of these shortcut device. So imagine here that these are the various type of TAVR calcification leaflets. So you can actually make cuts in different spots, maybe potentially using computer models to see where the cut should be, allow you to actually have the best expansion. So again, I think that's just one way of looking at bicuspid valve is trying to modify the leaflet and achieve better outcome in the long run. AI is simple because essentially currently our own technology is not there. This is going back to 2004. I think this is in India, Eberhard, right? This is the aortic regurgitation, actually one of the first generation using the core valve. The first patients treated was actually a lot of AI, a lot of aortic regurgitation, some aortic stenosis. So therefore, aortic regurgitation is always in the mind of the interventional cardiologist from day one. So obviously we need better valves. The current valves is really not designed for when valve has no calcification, or typically is one of the leaflet is prolapsing, or whether there's an incomplete closure. So obviously we don't have to talk too much more, but there's probably generation of new valves coming along that's specifically designed. For example, here there's J valve and you have the Jenner valve that potentially could take on that challenge. But that challenge obviously is, have to be addressed in the point that it is also the leaflet durability as well, because these patients have probably relatively younger, for example. Then we go to valve in valve, something always in our mind right now, because we have been putting a lot of these valves in. And if you look at the projection to the next decade, that you will have a total of valve in valve that is quite large. A lot of them obviously are the TAV in TAV. Obviously TAV in SAV is still possible, but the numbers of surgical valve being put in is relatively flat, and if not decreasing. Therefore, TAV in SAV numbers are smaller, but TAV in TAV is going to be growing. Unfortunately, we are going to be dealing with the generation of valves that we put in now, meaning when it deteriorates in 10 years, 15 years, we don't have new type of valves to do TAV in. So therefore have to take a look at what kind of TAV future that could actually decide on that. This is just a good picture that there's a lot of things going into deciding how to do a TAV in TAV, because it's complicated a bit of knowing exactly the different dimension, different type of the skirt, and different type of leaflet heights to really help you select what you want to do. Again, I think this becomes an issue of lifetime management, right? So what do you actually do first for certain type patients? Should you do surgery first? Because even though we want to do every single patient with AS with TAV, but sometimes it's better to really address the issue first. For example, if the first intervention is a surgical valve, then you redo a surgical valve is obviously not so good. Mortality be a little higher, recovery in a year is a little higher, mortality is higher as well. And TAV is SAV is relatively straightforward as long as you choose the reasonable surgical valve to start with. However, if your first intervention is TAV, then explant is always a little bit tricky because you typically end up with the aortic root replacement, potentially also root enlargement. But if you put a TAV in TAV, it looks good with the thumbs up, but still looking at the mortality of 6% and longer when your outcome that's not so good. So I think still this is an issue that we have to figure out in the next decade how best to do this, and whether we have to do, again, leaflet modification or otherwise to make these patients safer for us to re-intervene. Because there's issue of the neoskirt, the leaflet overhang, and also how well you expand it. So again, I think a lot of these factors need to be sorted out in the next few years to a decade so we can help the patients that we actually put these valves in the last decade. So I think, again, leaflet modification, we have one choice, shortcut, but maybe there will be better ones, and hopefully the price will be much better, because otherwise we can't really afford even doing this. I think the final thing that I want to talk about is really the holy grail. We need to solve the valve tissue durability, right? Because it is just like bare metal stents. If we're still using bare metal stent today, we still have to be talking about restenosis, have to talk about how to deal with these patients and so forth. we haven't really, or the surgical field, the companies have not really dealt with the valve tissue too much, right? We're still using the same bovine porcine tissue. Maybe we treated it, prevent anti-calcification. But we know that that's not the final solution. So therefore, the answer is that even though it lasts for these valves, valve prostheses are pretty good, but they deteriorate over time in the next 10 to 15 years, and some of those TAVR valves deteriorate even faster. So the question is that these are just pictures illustrating that we have to figure out how best to mix these tissue. And I think a lot of times people are concentrating, for example, in our Stem Cell Institute, is looking at how to replace myocardium, which is a much more complex process, is whether we should actually make tissue that is actually from, obviously, patient's own cells and mix a human valve tissue and allow us to basically have valve leaflet, as ChatGPT said, last 30 to 40 years, even though it's still about half of the natural life of a human valve. So I think the question is really, how can we make this? And I think there's still a lot of study going on, but still nobody has really come up with anything that is even close to being possible and testing it in a way that will actually help our patients have this valve for 30 to 40 years. So I hope that one valve for life is the aim, because if we have that, we have enough technology that actually can implant a valve quite well. And if it lasts for 30 years, then we really don't have a TAV and TAV issue. And we really don't need to worry about younger patients that, 50 years old that has bicuspid valve, for example, that we can deal with and put a valve in last for 40 years. They don't have to take Coumadin if they need to take, a mechanical valve. So thank you very much. Hopefully this gives you a little taste of the future.
Thank you very much, Alan. And I think we adjourn the session. Thanks a lot.
I have a luncheon session.